further ado, I'll want to address the elephant in the room, obesity. So, 135 million Indians are obese. Metabolic epidemic hai, lifestyle issue hai, and with that, you have an era of choices. Bariatrics hai, you can go for endoscopy, you have off-the-shelf GLP-1 injections. I'm talking about Ozempic, I'm talking about Mounjaro. With so much choice on the spectrum, one question is, who is the right candidate for these procedures?
Yeah.
Whether it is a medical or a therapeutic procedure, and what do you consider is the safest and most sustainable form?
Okay, wow, there's a lot of questions. So at the outset, let me thank our dear hosts for having me here in your wonderful oak room. I'm in the spotlight, and so I'm going to be a little nervous because I see a very educated, erudite crowd in front of me. So let me start that obesity is a big problem. All right. How many of you all in the room really think obesity is a problem? Let's have a show of hands. Okay, good. So all of you all know that, are aware that obesity is a problem. Do you know what problems it can lead to long-term effects if you don't do anything about it? And are you aware of doing anything about it? Are you doing anything to take care of obesity? A show of hands here. It could mean diet, it could mean exercise, it could mean walking, it could mean anything, sports, whatever. Consistently, not intermittently. Because we have a yo-yo for obesity. People say, I've become too much, I need to lose weight. People are telling me this, I'm getting conscious. It's purely for the look. Please,
Absolutely.
the driving point here is obesity is not look, it's metabolic. You have to feel good from within. Obesity is a chronic, recurring, inflammatory disease. It's a disease. By US FDA, it is a disease now. So it is no more a condition. We were happy when we had our midriffs big and happy. We would say, "Kaun se chakki ka aata kha rahe hain?" These were the statements we used to hear when we were growing up, which was, I think, which was wrong. But anyway, I want to tell you all that obesity can cause problems from head to toe. You can suffer from strokes, you can suffer from sudden cardiac death, you can suffer from fatty liver, which can be completely asymptomatic till its last end, which we call MASLD. You can suffer from kidney problems, you can suffer from heart problems, pulmonary, you can suffer from OSA,
Yes.
okay, sleep apnea, which can lead to sudden death. You can get thromboembolisms, you have orthopedic problems. So you see, it's a host of problems. Now, there are so many things one can do. But let's start at the bottom of the pyramid. And the bottom of the pyramid is diet and exercise. Really, put your hand on your heart and say, how much of you guys really do diet and exercise? Let's be honest. 3/4 of us, I don't think we must be doing anything. Let's be really honest. I see a few fit guys here, and women. So, they're good. I'm happy. But if I just survey the room, and if I just look at the BMI, now you know what is a BMI and what is the waist-hip ratio?
Yeah.
So BMI is a calculator for, and that's how we classify obesity. Either you're overweight or you're grade 1, grade 2, grade 3 and above, which is the super obese. If I scan the room here, I would say 80% of us are overweight. Out of that 80%, 50% of us are between grade 1 and grade 2 obesity. It'll be shocking. And it is silent. Are we really aware of it? Do we really calculate our BMI? Wake up and say, "Chalo, aaj main BMI karta hu." Nahin. We don't do that. When you go to a doctor, he does the height, weight, and then he says, "Oh, you are BMI of 30. What are you doing? You are grade 1 obese." And you're like, "Obese? Me? No. I'm fit. Look at my other friends. They're worse than me." See, the first reaction is denial. Okay? Denial. You have to overcome that denial. I mentioned metabolic. The reason I mentioned metabolic is because obesity has a lot of comorbidities which comes along with it. All right, it's whether you like it or not, they are friends which come along with obesity. And that's diabetes, blood pressure, lipids, you have osteoarthritis. Women can have PCOD, they can have, infertility, depression. These are huge things. So these are the things which we have to address with obesity and metabolic health. You mentioned, yes, there are a lot of things which have come in. The new kid on the block, the blockbuster, Ozempic, Mounjaro, they're all great. People are taking off the shelf as if they are like
Yeah,
chewing gum and gems.
absolutely.
You can just have it. They just, prick themselves and they say, okay, we are great. But it is dangerous. Please do not do that. Please tell your friends and relatives, whoever they are, not to take it without medical supervision. You need a medical supervision. The typical mentality is, छोड़ना है डॉक्टर को क्या देखना है. I know, मैंने पढ़ा है सब नेट पे, चैट जीपीटी ने भी बोला है, I will go to WebMD, it has told me, and I know where to take it, I'll do it. It's easy, but you have to read between the lines, and read between the lines is only done by medical professionals. Okay, like we know in between the lines what can occur. There are case reports of pancreatitis, there are case reports of renal eye problems by taking these medications. So it is a good drug, no doubt. It gives you as close to 22% weight loss, which is comparable to bariatric surgery, which can go up to 30% of weight loss. And so therefore, as I said, bottom of the pyramid is going to be diet and exercise. Once you can't do that, then you get on to some medications. We had a lot of other medications. There was metformin, sibutramine, orlistat. There were multiple drugs which were available, but they had their own problems. Then came the advent of the GLP-1s. The GLP-1s basically came in for those people with diabetes. But then they realized and said, hey, it's actually bringing the weight down. And so great. So that's how the whole blockbuster thing came up. And they said, forget diabetes, man. This is the market. And that's how everything was driven towards weight loss. And the company has done so well, I believe, and what I read, that the company's profits is more than the GDP of that country.
Oh, wow.
So it is so huge. The numbers are huge. As you rightfully put, 135 million and counting. I would go up to 140, 150 million in India are obese. I'm talking obese. Grade 1, grade 2, grade 3. That is 24% women and 23% men. Women outscore us here by just 1%, but we are catching up. Don't worry. And so this is a huge number. If you take overweight with it, the numbers are staggering. And therefore, we are called the #1 capital for diabetes, for blood pressure, for cholesterol, lipids. And this is the reason why. GLP, is it good? It is very good. But with medical supervision, and you know how you should be taking it. What is the dose? What is the correct dose we have to take? There's also Mounjaro, which is available. That's tirzepatide. The Ozempic is the GLP-1. The Mounjaro, the GLP-1, and the GIP-1, and the third hormone. So it basically works on 3 hormones. And so therefore, the results of tirzepatide are actually a little better than Ozempic. Okay. Ozempic is the drug which came in for the diabetics. Wegovy is the drug which is available for gastroenterologists, especially for fatty liver. So now I'm going to digress a little. I'm going to talk about what is fatty liver. Do you all know what is fatty liver? Have you heard of anything called fatty liver? Okay, it's an abnormal accumulation of fat in the liver causing inflammation and slowly destroying the liver. And so there is F0, which is normal, which goes up to F1, F2, F3, and F4. F4 is cirrhosis. Cirrhosis of liver is end-stage liver disease. Okay. And the only treatment there is then a liver transplant. All right? So fatty liver is one condition which can be completely reversed. Do drugs help? Does bariatric help? Endobariatric procedures help? What is actually proven by data is weight loss. Only if you document weight loss will your fatty liver come down. There are many drugs which are now available for weight loss and to reduce fat in the liver, but the bottom line is you have to do weight loss, diet and exercise. There is no shortcut to medicine. In medicine, you cannot have a shortcut. If you have a shortcut, it will be straight a long cut going up. So I don't think you want to have any shortcuts in medicine. So Ozempic, Mounjaro are great. There are more which are on the pipeline. There are actually 4 receptor analogs which are coming in. So those are the medicines which are available.
But just one data point. I heard 60% of the people regain their weight after 1 year of stopping these drugs, and probably 100% after 2 years. Is that correct? Or?
Absolutely right. So it's like in autoimmune hepatitis, we start steroids and sometimes we really don't know when to stop because they tell us, Doc, when do we stop? We said there's no stopping point, but there are guidelines to tell us when to start. So same way with the GLP-1s and the other analogs which are available in the market, they tell you when to start, but they do not tell you when to stop. They say it's lifelong. And when you stop the drug, over a period of time, as you said, 60% of them will slowly regain the weight. And the weight regain is a worse shock to the body than an acute weight loss. So you have to be very careful when you're doing it. So be informed, have an absolute informed decision when you all are going to be starting yourselves on Ozempic. It's no just a chewing gum or a chocolate off the shelf which you start and stop and start and stop. It's like, okay, I have a wedding in 3 months. Let me put the GLP-1. I'll lose the weight. I'll get into a dress, and then I'll be looking great. No, that's the absolute wrong way to do it. If you want to do it the right way. In year 2, 3, you're back to normal and probably gain a little more weight. So therefore, people knew about diet, exercise. They're knowing about these drugs, and everybody knows about bariatric surgery, right? We've all heard about bariatric surgery. So they know about bariatric surgery. There was this huge gap between drugs and bariatric surgery, which was least invasive, all right, incisionless, quick time to recovery, and showed not so equal but close to bariatric surgery results, and that's endobariatric. Have you heard of this word endobariatric? Yeah? Wow, learned crowd, yeah. So, good. So in endobariatric, there are 2 procedures which are now being done commonly. That's the intragastric balloon and the endoscopic sleeve gastroplasty. It's not sleeve gastrectomy. Gastrectomy is cutting the stomach, is dissecting the stomach. Half of the stomach goes away and that's it. This is gastroplasty. All we're doing is we're making the stomach into a small volume. So we have the intragastric balloons. There are 2 types of balloons which are available. These balloons are made of silicone. One is the Orbera 360, which is the fixed volume balloon, and you have the SPATS 3, which is the variable size balloon. So there are various types of balloons. How does this work? This works basically by occupying the lumen of the stomach, and you're in a constant state of fullness. And so therefore, and it induces gastroparesis. That's where the whole theory of losing weight comes down. Early satiety, gastroparesis, you lose weight and the volume. So that's how the intragastric balloons work. It is done endoscopically. It's an OPD procedure. You don't need to be admitted in the hospital. The procedure is done within 20 to 40 minutes and even less when you get the expertise, you know how to do it faster. The only thing people ask, Doc, what about the side effects? Yes, with the fixed volume balloon, there could be nausea, vomiting, which can be there for up to 2 to 3 days and then completely goes away. You have to be on a hypocaloric diet and you have to have a basic exercise regime. That means you can just walk for 45 minutes every day, and after 3 months, you can start on some light training for toning your body, for toning exercises. What we have started doing now, and we've seen a beneficial effect, is we know that the balloon gives us 10 to 12%, up to 15% weight loss. And the GLP-1s gives us around 20% weight loss. When you combine both, so you're making both symbiotic to each other, helping each other, not competitors, but co-partners, we can gain a weight loss up to 25 to 28%. And so you're achieving close to a bariatric surgery. And the advantage is there are no complications, there's no surgery, there's no cutting. It's completely reversible, and that's the beauty of this procedure. You feel, Doc, I don't need this, I'm okay. Come, we puncture the balloon, we take it out. It's very simple. Putting in, there are no complications. Coming out, you have to be careful because there are some case reports of perforations and lacerations, but under expertise, the complications can be as low as 0.1%. In medicine, there's never 0%, so it's 0.1%. So that's about the intragastric balloon or the Orbera 360. The SPATS balloon is a variable balloon. The beauty of this balloon is you can vary the size of the balloon. So there's no nausea, vomiting with this. So we put the balloon, you have a weight loss. Once you plateau with the weight loss, you come back. There's a catheter which is attached to the balloon. We pull it out with specialized instruments through an endoscope. We push in water, increase the volume of the balloon, push back the catheter, go back, you'll again drop weight, and in 1 year, you lose up to 18% of weight loss. So that has shown a little more benefit. There's a study which was done where this balloon has shown to reverse fibrosis, F3 fatty livers to normal livers because it showed good amount of weight loss. So this is the SPATS balloon. The endoscopic sleeve gastroplasty, this is a more specialized, it's a more advanced endoscopic technique. It has to be done only by advanced endoscopists and people with expertise. This is basically a specialized scope and suturing devices attached to the tip of the scope, and that goes into the stomach, and we take sutures inside the stomach, and it's all done by specialized equipment which is done with one of my assistants and myself. And all we do is we just take sutures from the anterior and the posterior wall of the stomach and we tighten the sutures, and there are 6 to 8 sutures taken. I mean, people get scared. Sutures, nahi doctor sahab, apne ko nahi karna hai, taka waka nahi chahiye. Arey baba, take andar hai, bahar nahi hai. No, but then once you put in this thing, it won't be, it's irreversible. It is completely reversible. You don't feel like there are specialized instruments, we'll go in and we'll just cut the sutures, open it up and remove the sutures. So it's completely reversible, don't worry. In this procedure, after 3 years, that's what everybody experiences, that's what the data is. After 3 years, the sutures kind of loosen up and they open up. That's when you might have a little bit of a regain of weight. And why that happens is because the stomach is a very muscular organ. It's a capacious organ, it's a very muscular organ. It has strong contractions, and obviously your sutures are going to get loose after a while. So all you need to do is come back, we reinforce those sutures, take a second line sutures, and you're done with it, and that's it. And you can again go back on your weight loss journey. There are no specific contraindications. The other question which you said that when do we start all this? So above a BMI of 25, people are good for balloons, above 25 to 35 BMI. 30 to 40, you can do ESGs, all right? Above 40, then we kind of, either you do a balloon first and then follow it up with the ESG, or you do ESG and you add a GLP-1. So these are all new forms of therapies which are now coming out, called hybrid therapies, or you can call it cocktail therapies, all right? So this is how we are managing our patients with obesity. Above BMI of 25 to 30, honestly, if you really ask me, you should just do diet and exercise. Just do that. That is good enough. You really don't need to, go through this. The other thing people ask me is, oh, but doc, there's a foreign body. What's going to happen? There's a foreign body in there. It's not good. So I just tell them, women have artificial breast implants, they have butt implants, they have thigh implants. Those actually get infected. But my balloon will not get infected. Why? Because of God. God has made this human structure so fantastic that He gives us acid in the stomach. No bacteria survives acid in the stomach or fungus, except for H. pylori, which is a very smart bacteria. That's another discussion. But I would tell you, that's why these balloons do not get infected. There is no infection which can cause the implant. So be rest assured that there is no infection when it is there in the stomach. The other question? No, I forgot.
Sustainability.
Sustainability, yes. As I said, there's no shortcut. It's not there that ki dal diya bhi masti karo. No. There is diet and exercise with this. We will put you on a hypocaloric diet, all right, not more than 800 kilocalories per day. You can go up to 1,000 if you want. You have to exercise every day. 45 minutes of walking every day. How many of you all actually you're really fit? I don't need to be asking these questions to this crowd, but I'm sure. I mean, we are in a lake city. I mean, the country is lake city, so I'm sure you all must be taking a stroll every day in the morning to the lakes, Fateh Sagar and all. I'm sure everybody's going there. I'm not talking about eating the samosa after that. That's what we do. So I don't know about you guys, but so walk every day, 45 minutes. I think very important. And then after 3 months, you need to start putting in some weights and resistance exercises needs to come in. The reason why I'm telling you this and more proteins and more muscle is because if you want to start any GLP-1 or tirzepatide, apart from fat loss, you will also have muscle loss. Now, to counteract that muscle loss, you should start yourself on high intensity or resistance training to build up that muscle. So by the time you build up your muscle mass, you're losing your fat mass, you start the GLP-1, and then the muscle loss will counteract that by your GLP. So you won't lose as much muscle mass as what you would if you were a naive patient who started using it right from day one. You get it? So you need to balance the both. So this is again a new concept which we are all looking at and which we are telling everybody on a forum like this, that you need to exercise. So that is important. If you sustain this, it's very good. Obesity begins here. It doesn't begin here. It begins here. How serious are you? And I always ask my patients, how serious are you to lose weight? You just come here to say, ki, Doctor Saab, thoda vajan kam karna hai, this, that. Okay, I want to join the film industry. I want to do this. I want to do that. Then it's a whole different discussion. But for me, obesity is metabolic. You need to correct your metabolic parameters because you cannot be 65 and be obese and have metabolic parameters which will affect your quality of life. No, that is not acceptable. Your quality of life at 65. Why is it called a golden period in our life? Because after 60, they say you actually start living your life, and you have to be a fit 65. You cannot be putting in insulin and then going to saying that, okay, I might go to base camp. No, it's not done. You need to be fit now. And when you do that, you do it now. I in fact tell people that losing weight will actually make you save a lot of money. Because if you have cardiac issues, it's a straight 15 lakhs for stents. If you have knee problems, it's a straight 10 lakhs for 2 knee joints. If it's a spinal surgery for 6 lakhs. Diabetes and blood pressure medicines, it could be around 50 to 60,000 or 1 lakh per month. So it's 12 lakhs. You take that for 10 years, it's 1.2 CR. So by the time you're 65, and if you have this thing, you need at least a cash pool of 2 CR to take care of yourself to be fit. Or simple, as a health insurance, do this now, and by the time you're 65, you're fit and you've actually saved. So I'm sure all of you all are businessmen here and financial guys. Do SIP in your health. Okay? And then at 60, you can do SWP, systematic withdrawal plan. Means you can start enjoying all that with good activities and all that. So that's an important thing. So it can sustain. It's up to you. I've had one patient who put in a balloon. She flew in from the US, and I did the endoscopy, and she had some ulcers, and I said, sorry, I can't do it, and go back. And she was one of those real, VIP patients from USA. I said, but I'm sorry, you can go to some other gastroenterologist, but I'm not going to do it because it's a contraindication. It's a relative contraindication. I cannot put the balloon in you. So excuse me, I'll see you after four weeks. In my mind, I thought, Gaya. Now this lady is not going to come back to me, and that's it. But to my surprise, she came back after 4 weeks. And I said, have you taken the medicine? She said, yes. I said, great. And then she said, Doc, I have to tell you one thing. So I said, okay, now here comes the usual thing, which people say, Arey, I spent so much, I went back, and this, forth, it was so much of a trouble. I said, go ahead, tell me, what is it? She said, I've come back to you because you were honest and you did not do it and you did not compromise on my health. So I knew you were the right guy for me. And that's why I've come back.
Beautiful.
So I said, great, wonderful. So put the balloon, she went back to USA, she came back. She lost around 10 to 12 kilos. But she was not very happy with her weight loss because I assumed that she would lose around 20, to be very honest. And 20 she would have been like a wow, okay? Just looking like a wow, okay? Something like that. So then I told her, sit. Now tell me your routine day, what you did. I used to get up, I used to exercise, then I used to go to office, come back. And I used to have my salad, I used to do this. And then I used to sit with half kg of Haagen-Dazs ice cream every night. I said, what are you doing? What is the calories of that ice cream? You know, she said, but dog, what to do? Anyway, that was like a little light story, but she lost weight, 10, 12. Important is not losing weight. Important is not seeing the weighing scale going to the left rather than going to the right, but it's the waist-hip ratio. You have to lose that waist-hip ratio, which is very important. A simple study done in UK just showed that a one gain of our belt, one gain and one loss. One gain, 90% cardiac risk.
Oh.
One loss, 90% fitter. Just one whole of our belt. It was an amazing study. I mean, it's so simple, but it just showed that. So, if you lose inches, you are fitter. You might not look thin, you might not look lean, but if you lose inches, let me assure you that you are metabolically fitter. So that is important because some people's body structure, bone structure, build can be a little bulky. So they might not look lean or petite as what they would want to look. So that is the
Wow, that was really insightful. There were few parameters which I would have not understood what you've explained. Thank you so much for explaining it. But ultimately, it all is about food eating, right? So in India, 20 to 30% of the people face bloating, which they sideline with gas. We're talking about the gas issue.
I
Yeah.
think 80-90%.
80-90 here. Some of your patients here. So my question is, what are the red flags? What should be the sign that you should not just ignore the bloating?
So there are no red flags as such in bloating, but yes, but if you're bloating and you lose weight, there's unexplained weight loss, loss of appetite. If there is some kind of bleeding, rectal bleeding, then obviously it's not just bloating. There is something sinister happening. Either it could be ascites, that is water in your stomach, or there is some malignancy somewhere which is causing a problem. Bloating is typically abnormal gas or gas in the abdomen. It could be upper, it could be lower, it could be colonic bloat, it could be a small bowel bloat. It comes through contaminated food and water. We have a lot of bacteria. We all eat outside. There's contaminated bacteria. The bacteria produces the gas. The bad bacteria produces the gas. And the typical what we get to see is SIBO, small intestinal bacterial overgrowth. And that needs to be investigated. There is a treatment for that. It's a 3 weeks to 4 weeks course. You take that and you're done. Probiotics is just for general health. You can just take probiotic because probiotics are known to reduce inflammation, to reduce a bit of gas. It reduces colonic inflammation. It forms the stools better. So this is the importance of probiotic. The probiotic concept came thousands of years back from this country.
Ayurveda.
All right? And it was in our simple curds, chash, which had the best probiotic. And we completely did not look at that, sadly, and we had some Western people patent it and then sell it to us. So that is the thing. So probiotics are important. You can take them every day. It does not matter. But it has to be billions of spores. It cannot be few millions. So read which probiotic you're taking, and you'll know if it is showing you 10 billion, that's good. 20 billion, that's great. 40 billion, fantastic. So don't take it in millions, but take it in billions. That's all I can say. The commonest, I'll tell you, in practice in the last 20 to 25 years, I have seen the commonest cause of bloating is people who eat too fast. So they swallow a lot of air. Aerophagia, it's called. So, because we are all busy, right? We've got no time to eat. We've got patients, we've got business clients, we've got to make tons of money. So the plate is here and we're eating and we're talking, and in that fast eating, we're swallowing air. When you eat fast, you swallow a lot of air. That's why you have to eat slow. So I say, swallow your food, chew your water. Very important. Okay? Swallow your food means you chew so well that you swallow it, and you chew your water, so you drink less water. Because every time you drink water, you're swallowing air. Every time you take big chunks of food and gulping it down, because that meeting is going to start in 10 minutes and I don't have time, and I have to finish this food, otherwise my wife is going to kill me when I get home. So I have to do that. So that's the thing. Okay? So so that's the whole thing about bloating. It can be discomforting. It is mainly socially unacceptable, nothing else. And a lot of women say, doc, I'm like this. Now look, I'm 4 months pregnant. What do? I
Yeah.
don't fit into my clothes. I just bought this lovely dress. Help me do something. But this is the simple thing you need to do. That's it. Exercise again for bloat also. Just exercise and you'll be fine. Purse your lips and breathe rather than,
Okay.
because again you're swallowing a lot of air.
Okay.
If you have a severe, especially for COPD patients, people with lung problems who have COPD, I tell them you should use a straw and drink your water, because that again eliminates swallowing a lot of air. Because air in a COPD patient, when they bloat, it pushes up the diaphragms, it causes more problems in breathing. So this is one small little trick, a hack, where you can do this and they will be a little more comfortable. Any questions? I mean, Kapil, any questions?
I have a question.
Yeah.
There are so many people, the principle behind all the surgery and drugs is a calorie deficit, being in calorie deficit. Because if you had gone through the bariatric surgery or if you are putting balloon in your stomach, how they work means you'll eat less and that's how you'll lose weight. But there are so many people who are already eating less but still not losing weight. So which drug or which technique is good for them? They are very regular with the exercises and they are eating actually 1,000 or 1,200 calories.
Yeah, that's a good question. See, those are those real unfortunate people who, in spite of doing anything, they say, doc, I swallow air also, I put on 1 kilo. Yeah, that's the sad part. For them, it's going to be lifelong diet and exercise. These are add-on for such people. Calorie deficit has to be there for such people because their body has a tendency. There's a genetic makeup of this, so that you really cannot help such patients. People try to tell, oh, but you can do this, you can do that. It's all temporary.
And if it is an effect of any steroid, then how we can come out of this?
See, the effect of steroid, if the steroid, like our patient with autoimmune hepatitis, they require the steroids for the liver. The best is to get an ESG done for these patients, that is sleeve gastroplasty. So you're just reducing the stomach content. Instead of a 1,000 ml stomach, now you're making it into a 500 ml stomach. So you're going to give them sustained less food, less calories, countering that with a steroid. There's no head-to-head study which I can really tell you that whether this really helps or not, but this is just as per experience, one can do this. Lower the dose of the steroid, be on a maintenance dose of the steroid, get down the water weight, get on the exercise, you will lose weight. Especially for those young ladies of PCOD, because they do everything, and they're really fed up, they're tired, they do everything, and then they're also under the pressure. They need, they have to carry forward the legacy, and they're just not conceiving. And so these patients, I've had around 8 to 9, where I've put a gastric balloon. They're all between the age groups of 24 to 32.
That's young.
And young. And they lost a modest, 8, 12 kilos, but documented sonography, ovaries normal. Studied ovaries are now normal ovaries. I think because of the weight going down, inflammation going down, hormonal imbalance getting balanced, and doing that.
Yeah.
So I think that is a very good takeaway also for the young PCOD girls who are suffering from this, and who are infertile. Their fertility rates just shoot up, and that's a good solution for them. Similarly, for people above 65 who've got comorbidities, spinal problem, osteoarthritis problems, cannot walk. They say, डॉक्टर साहब आप तो बोल रहे हैं काम वॉक करना, ये
चल
तो
ही
जवाब
नहीं,
दिए,
हाँ.
हम तो चल भी नहीं सकते, अब क्या करें? For them again, good thing is an ESG, because they'll have a graded weight loss, and then put on a GLP-1 for them. They'll have a good weight loss, and then you will see the quality of life improving. Patients with a Pickwickian syndrome, those are those real super huge obese people who even sleep while they're sitting. Okay, yeah, Pickwickian syndrome. So for them also, they're the super obese. We can do hybrid procedures, add on GLP-1, but the bottom line, diet and exercise. Your dietitian and nutritionist has to be by your side. She is your partner for that. You cannot let her go.
This
She has to be
question
with
comes
you.
from a dietitian.
Is it okay for a PCOD person to have metformin अगर diabetes नहीं है तो just because insulin resistance
Yeah,
is very
yeah,
common?
yeah. They give it very commonly, and metformin is I think one of the known treatments for PCOD, for hormonal imbalance.
Indians, what I have read is, I mean, I'm not an expert like him, but Indians have this lean obese concept, right? You are lean, but you are obese from inside. Means you have a lot of visceral fat
Around
surrounding
your
your
organs.
Your BMR is very, very low because your muscles are low, and that's the reason could be one that even if you're eating 1,000 calories, you don't lose weight. I think good is for them to start doing extensive, I mean, gradually going and increasing muscle. I mean, muscles are your glucose guzzlers in your body, right? And there have been recent studies, right? If your thigh muscle is the largest muscle of the body, the most important muscle, and the better it is, that impacts the quality of life, because one, obviously you will not fall into all these metabolic diseases, and second, your risk of
Falling down.
in an old age reduces drastically if your thigh muscles are strong. So, if everybody can focus on thigh muscle building, I think that's the single most important step you can
Yeah,
do.
yeah. Just to take that point forward, that's an excellent point. It's just, I mean, thighs, I would say, if you have good legs, you have a good life.
Yeah.
Yeah,
Because that will just take you
absolutely.
everywhere. All right, so that's important. Lean obese, we also call that sarcopenic obese.
Yeah.
They're the thin obese. So that's the irony. They're thin and they're obese, and that's where visceral fat and all this comes in. So that's again all got to do with hormones. You have to correct that hormones, give them, hypocaloric, more protein, build on the muscle mass, and it's more from than a nutritionist point of view rather than more of a gastroenterologist point of view. We have to only be careful whether those patients do not develop fatty liver or even fatty pancreas. Now the concept of fatty pancreas also is coming. That's fat getting accumulated in the pancreas, which can cause acute pancreatitis. And as you all know, acute pancreatitis is a real bad disease to have.
Yeah, you all know.
Check if they're also sitting with a
The
tummy.
young doctor we have, I need a question from you. What do you think? I mean, you're set. Yeah.
No, no.
Like the abdominal obesity, so this is very true that in Indians we have more of visceral fat and abdominal fat rather than the BMI.
It's called apple core obesity, and the women have pear-shaped obesity.
So abdominal circumference and waist hip ratio is more important than just the BMI for
So
Indians.
nowadays, it's a
Absolutely.
combination of the two which is considered. To declare somebody an obese, you generally take the combination of the two. So it's BMI and the waist size. So Dr. I have one question.
But you know why? I'll just take that forward. Is why? Because BMI is very easy to calculate, so it's more easy. It's more layman,
Generic,
to
yeah.
get the hip ratio and to explain to them, and then what? Then they have 100 questions in that. Am I doing it right? Is it at the navel area? Is it a little below the navel?
Absolutely.
So that becomes a little tricky. Go ahead.
So in autoimmune disorders, the people who are on a lot of, methoxylates and everything, so they experience unexplained weight gains, at a certain stage. And they may be, let's say, a BMI of 25, not even the, wrong waist issues and everything. Which lifestyle strategy, or whether they should come to you for the weight guidance, because with autoimmune disorder, whether whether it is a rheumatoid arthritis or it could be scleritis or anything for that matter. Kuch na kuch to over a period of time they tend to put on. And they have to be, let's say, more conscious than people who have, let's say, healthy bodies.
Yeah. So autoimmune, basically I see autoimmune hepatitis. And some of them can become autoimmune cirrhotics. All right. And so therefore we just give them a cirrhotic diet, the standard cirrhotic, salt restricted, fluid restricted, restricted protein. But if they are not cirrhotic and they're just autoimmune, then you give them a moderate amount of protein, 40 to 50 grams of protein. You moderate their salt intake, and fluid has to be moderated, for no doubt. Now what drug they are on, methotrexate, just steroids, they are on a combination. Then depending on each patient, then you have to just tailor make that diet.
So do you think that, the gastric sleeve surgery or, all these things will work for them? Because I feel I've seen them that their BMIs are like 25, even 24, 25, 26. Their weights are also not too high, but they're experiencing weight gain. So if you calculate on the scale, it is coming right. But वो कहते हैं ना फुलावट जिसको आप बोलते हो जिसको bloating भी कहते हैं, that's very common in autoimmune disorders.
So in such patients, you have to first rule out ascites. You have to rule out edema because they could have a lot of water retention, and that is the reason why their weight is going up. Okay, so you have to make sure that they don't have that much water. They're generally wet patients. You need to keep them dry so that their weight will automatically come down. The bloat will automatically come down. So this is important that you need to understand first. So that's the reason why.
It could be ascites or it could be water or anything.
Yes.
And that's insightful, and that those questions are coming from the best nutritionist in the town.
Yeah. Okay. There you go.
So yeah, yes.
Doctor sir.
My experience as a pediatrician,
Sure.
young adolescent girls, we see most of them are obese, most of them. It is because of adolescent period, they got their hormonal changes also, number one. And number two, their demand of the protein also increases, but they are eating the junk food nowadays more. So eating the junk food, gaining weight, psychological problems, and we have seen also the children who are hyperactive children, who are going to be autistic, they are also more weight gain also. And these children who are becoming obese, they have recurrent pain abdomen also at times. And we got their sonography done, it showed mesenteric lymphadenopathy also multiple places. So this is showing that they are having recurrent infections also. So that is why we have in adolescent, we have to say them for the exercises, dance exercise, because the girls, they feel very shy, and it's also one of the psychological factor. Again, it is increasing the obesity.
Yeah, it's a vicious circle. Yes.
Again and again.
It's like a social stigma for them.
Social
Yeah,
stigma
yeah.
for them. This I just wanted to.
No, absolutely. It's such a valid point. I mean, good you brought this up because unfortunately, below the age of 18, there is no medical therapy. US FDA has not approved sleeves or balloons for children. We don't have them. And so therefore, it's becoming a bit of a problem. And I mean, now it's becoming a major problem to try and get these kids, because all these kids are now becoming couch potatoes, literally.
Yeah.
And they have their phones, they just don't get out. Like for us, when we were small, we used to always be out. Our parents used to drag us back home. That come in. Now here we have to push our kids out. That go out and play. Do some form of physical
Absolutely.
activity and all, which they don't do. So that's a point very well taken. Drugs are there, but I don't have the experience because I'm not a pediatrician, so I really don't know. But again, diet and exercise and all the ills of the world, you have to tell the children no ice cream, chocolates, fast food, all these fast food joints. I don't want to name anyone, but all the fast food joints have to be
They order
in a
4 days
moderation.
week.
And now, unfortunately, we have restaurants in our house
Yeah.
because we
Yeah.
can just
Blinkit it or
I don't want to name anyone again, but we get food delivered in our houses. So we have all sorts of cuisines and restaurants in our houses, and so that's a big problem. I think the stress has to be on outdoor activities, encouraging them to do some sport, some form of sport, not just a hobby, but they have to do some form of a sport which will be good. It could be swimming, it could be just walking in the pool also, which will tone your muscles. It could be playing badminton, table tennis, something which will give them some. Pickleball these days is very famous. A lot of kids want it, so they want to go there. So I think you should just encourage your children to go out. The take-home message is just encourage them.
Two small questions. First question is hypothyroid patients. We have a number of hypothyroid patients.
Yeah.
The effect of the drugs Mounjaro and Ozempic. How effective sleep gastroplasty or Mounjaro Ozempic are in hypothyroid patients who are on drugs?
So that's a very good question, Kapil. The balloons which I have put for the hypothyroid group, there were around 22 women. I did an initial study of my first 50 consecutive gastric balloons. So 22 of them were hypothyroid. I got a modest 6 kilos weight loss, 6 to 8 max. They never went up to 20, 22. I was wondering why. But they had an interesting 4 to 6 inches waist loss.
That's
So-
what I was saying. That is what I should have to have.
So they lose their circumference rather than their weight, and that's probably got to do with the hormonal structure of their body. The GLP-1 and all will actually worsen because these people already are gastroparesis. They have gastroparesis, and the GLP-1s they induce gastroparesis. They'll cause more nausea, vomiting rather than giving relief. They'll get a little more problematic.
They tend to have a lot of post-procedure problems. They keep on calling you, patient undergoes, they keep on calling you for frequent vomiting,
Yeah.
bloating, excessive bloating.
That's quite insightful. You can't just buy the drug and apply it.
No, you
That's
can't. And
there.
in fact, for the gastric balloon, those ladies, the nausea, vomiting within 40 to 72 hours, it actually goes away. And they say, no, so we're fine. It's not the first day. The second and the third day is the worst. And then it just kind of goes away. But these ladies, up to 8 days, were having nausea and vomiting, which was a problem. And I was wondering, my God, what is this? Like, initially you're really stumped. You really don't know what's happening. But then you put them on your prokinetics, you put them on acid suppression, you give them reassurance, and then they kind of, say, okay, and then they're okay. And then it's a smooth journey for them. But the weight loss won't be enough, but their waist loss will be good. So I think we should again concentrate on the waist rather than on the weight.
The second question that I wanted to ask you was, at what age are all these techniques applicable till? When you draw the red line, you are above 65, please do not try it. Or are you targeting an age group of from 18 plus to 55 or 65?
Good age, right
What is
age
your
bracket.
group? Because as the patients or as the people get older, they are having so many other comorbidities, accounting, hypertension, so many other things, stroke or many other problems. So at what age there is bound to be a drug interaction or a procedure-related complication? The risk becomes high. And then if you want to say, no, you try only diet and this, we are not going to give you any drugs or any procedure.
So endobariatrics is approved from the age 18 onwards. It can go up to 70. We can go up to 75 also if you really push yourselves. But 18 to 70 is a good parameter to do. The problem with the elder generation or the senior citizens is because of so much of comorbidities, they have end stage problems of their organs, of their eyes, of their kidneys, heart. So you have to be careful because all these GLP-1s and all these can have an effect on these. So you have to be careful.
The disease has already taken or hooked on to, or has already caused organ damage. Yeah. So you're going in and you doing some procedure, I don't think it is going to make.
The procedure is not going to cause any problem. It is well tolerated up to 70 because now we have variable balloons or you have ESG. I mean, it's only for the sleeve gastroplasty. The only complaint the patient has is pain in the epigastric. There's the upper area where we tighten the stomach for up to 1 day to 2 days max. After that, it's smooth sailing for them. For the balloon, the nausea, the vomiting can remain up to 2 to 3 days. But with the SPATS balloon, it is 0. So we have overcome those hurdles of procedure-related side effects. They are now very minimalistic. So that should not be an issue. But with the drugs, if your creatinine is a little high because of chronic diabetes and a high HbA1c, like 1.5, 1.6, you have more of a tendency of developing acute pancreatitis. And trust me, you don't want to have that disease. All right. So you have to be careful for that. So those are the few things one has to take care of.
I hope the non-medical people are understanding the terms. Please,
I don't think so.
they won't. So please let us know if you're not understanding something, because I'm married to a doctor family, so I get it. So I won't be able to match your shoes there.
There's a fad these days about anti-inflammatory diets. A lot of celebrities have lost weight. Anti-inflammatory diet. Anybody would like to say something? What is anti-inflammatory?
In fact, I would like to know which celebrities have you touched in Mumbai? Coming
No,
from Mumbai,
I
we can
can't
have
say
it
that.
off the record.
I can't say that. I can't say that. No, really, no, I can't say that. Because it's a complete patient confidentiality.
Yeah.
But they
Yeah.
come to you.
They've been, yeah, like, we do a lot of masti, all that is there. So you can understand which celebrities, okay? Yeah.
That we will have to meet him in Bombay.
Yeah, for that we have to meet in Bombay, or after the event you can ask.
I mean, there have been some industrialists also
Yeah.
who are very conscious of their weight, and I'm happy about that. There have been some politicians also, but yeah, and there have been some models.
Mm-hmm.
There have been some, and there have been some Bollywood actors and actresses, but that's about it.
Okay, ये hidden ही रहने देते. Okay, so my next question would be related to antacids. People are popping them day in, day out. How safe are they? I know a lot of people who are taking them on a daily basis. Is regular use of antacid safe?
So antacids are basically medicines which reduce your acid level.
Yeah.
The body does require acid. Remember that. It cannot be achlorhydric. Means you should not have no acid in the body. That's not good, because that can cause other problems, and that can cause long-term cancers of the stomach.
Oh.
All right. So you need some acid in this thing. When the acid production becomes problematic or becomes symptomatic and causes symptoms, that's when you say, I've got acidity, burning, jalan, pain, bloating. That's when you start popping in antacids. Antacids are very, 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 very safe. There is no problem. You can have them for a long time. You can have them intermittent. There's no. There are multiple which are there. There are plethora of antacids which are available, right from proton pump inhibitors to now the potassium channel blockers we have. So there are the whole host of antacids which are available, which started from ranitidine to omeprazole, lansoprazole, pantoprazole, esmoperazole, rabeprazole. These are all the antacids which are there. You can pop in anyone you want. Yes, timing is important for the PPIs. They have to be taken 20 to 25 minutes before your meals, and that's the best time when you will get the effect. If you're taking blood thinners, or if you're taking any bronchodilators, then this group of PPIs which I told you, they might have an interaction, or even warfarin, blood thinners like warfarin, clopidogrel, they can have some. These are basically medicines to liquefy your blood, clopidogrel and warfarin. So they can interact with them. So therefore, the next best what one can use is a PCAB, that's a potassium channel blocker, or a dexlansoprazole. Okay, that is also available in the market. The newer ones in the market are now the potassium channel blockers, which are called PCABs, and there is fexuprazan, there's vonoprazan. These are all the newer ones which have come into the market.
Also, just one question. With colistomy patients, colistomy is called gallbladder removal essentially. So when you have stones in the gallbladder, a lot of times the doctor will recommend you to remove the gallbladder. So with a colistomy operation, there's a lot of digestive issues post-operation. Sometimes we tell them it will subside within 1 or 2 months. But I've seen so many patients, let's say they had 2 or 3 years for the colistomy and they still suffer from digestive issues. What is the solution? How do you tackle such patients?
First, let's ask the surgeon. No, Kapil,
All eyes on
take it.
you.
I thought, let me put him on the spot. No. So, cholecystectomy, as you're saying, what is the function of the gallbladder? The function of the gallbladder is to.
Concentration of bile is the function of
Just to store the bile. That's all. That's all it does. It just stores the bile. Okay, correct me if I'm wrong. But stores the bile, forms stones, so that the surgeons have some work. On a lighter note. No, but to your point, what happens is when you remove the gallbladder, the bile juices which are there, it gets directly goes into the duodenum. It can cause bile acid injury to the small intestine. Bile acid induced diarrhea as they can get, and that can produce, bloating and all. So what I typically tell my patients is after a cholecystectomy, be on a fat-free diet for 12 weeks. Once you're off a fat-free diet for 12 weeks, your bloating and all your other symptoms become very minimal. They will do well. So this is the reason. The exact reason I would not be able to tell you, but I know that it causes bile acid diarrhea. Bile acids produce a lot of toxic injury to the small intestine, damaging the bacteria, and hence there is a flushing out of good bacteria, bad bacteria producing gas, and you get a lot of bloating. But people do not also stop eating. They are still eating fatty foods. The fatty foods used to get digested because of our bile and because of the gallbladder supporting that. Now that support is gone. So therefore it is essential that the fatty foods are kept to the most minimalistic thing. But I think let the surgeon have the last word because they are always right.
It's basically post-cholecystectomy syndrome. So it is one of the features. It's post-cholecystectomy. No, the problem is what he's already answered, and I don't think we have got it. Is the last sentence what he said. People don't change their diet. They feel that after undergoing surgery, they are going to be completely fine. If they are going to follow what has been discussed, lifestyle,
You
as
want
well as
your
diet,
drink
is
to be
not going
repeated?
The problem is they take increasing more of fatty foods. The diet actually increases. When you're going to take a PPI or any anti-acid, you are going to feel very hungry. Especially after the gallbladder, the diseased organ has gone out of your body. You are going to put on more weight. In the tendency, you tend to eat more and you are going to feel bloated. So the simple thing has to be done. You remove the diseased organ, please follow the diet as has been discussed.
Excuse me, sir. What is your experience with cholestyramine in terms of bile acid diarrhea for managing that?
Oh, that's a very good molecule. Cholestyramine is very good.
Please simplify for us.
So these are bile acid resins. What he's asking is these are substances which bind the bile. Okay, so once the bile is bound, you don't get you generally get bile acid induced diarrheas. So no medicine works. Your loperamide will not work. Nothing will work. Probiotics, antibiotics, nothing. You require bile acid resins which bind the bile, and because of the binding of the bile, the diarrhea incidence and the frequency comes down. I mean, more in detail, I think you can also tell us.
I just wanted to know your experience with that because it is not less palatability is an issue with cholestyramine sachets, like what usually patients complain of.
Yes.
And we manage post-cholecystectomy diarrhea. So, like, what do you do for that? Like, do you prefer giving them cholestyramine or just fat-free diet for 12 weeks? That's it.
I've actually used cholestyramine only in 2 patients so far in 22 years. We don't really require them that much, but it should be in the back of your mind. And that was pure bile acid induced diarrhea because they were passing green stools, all right, and the stool examination was done, and obviously we saw that, and we knew why. Post surgery. So, a lot of bile acids, diarrhea, and that's the reason why.
How common are these procedures? How many do you do in a month?
The
weight loss, I mean, including the balloons and ESGs and all.
Well, after GLP-1 and tirzepatide, it has really dropped. But otherwise, it would be at least 1 or 2 balloons a month. And, the ESG have started doing in the last 3 years. So we do around, again, 1 to 2 in 2 months, 1 procedure. Because I talk to hundreds of people, but 1 or 2 only will turn up saying, ki, no. But the good thing is insurance. Where's my insurance man? Yeah. So the insurance, the IRDAI has now said that these procedures can be covered under insurance because obesity is a disease. So now they can be reimbursed, they can be completely taken. And so therefore we are hoping because of the insurance, because anybody who comes, because these procedures do cost. The accessories do cost. A balloon cost would be around somewhere between 1,25,000 to 1,75,000, depending on which state and taxes and all that. Octroi. The ESG has got a lot of accessories. That basic accessory package itself, only the accessories, is 2,25,000. So obviously, for a person to shell out something which is not so important but wants to lose weight, they find that a big pinch. But the same person can go and buy a 11 lakhs watch and say, oh no, nothing, it's all right.
Yeah.
So that's a big discussion we have amongst our medical fraternity, that how patients are so ignorant about their health that when it comes to personal beauty, they will do whatever they want. But when it comes to health, it's absolute finance is zero. So thank God there is insurance which is now there, and patients are now inquiring it, and there is a certain format we give it to them, and most of the patients do get their money back. If not full, at least more than half. If also they get, they are happy with it. But most of them, the claims they get paid. So that's a good thing that the IRDA has done that.
Absolutely. There's an awareness towards obesity. It's a disease, after all. So, yeah,
How
sure.
do you manage micronutrient deficiencies then?
You want to repeat your question?
Micronutrient deficiency is all orally and through medications.
No multivitamins are given after the surgery.
For balloons and this thing, whatever they have been taking, they can continue that. You don't get that vast a micronutrient deficiency as compared to bariatric surgery like a sleeve or a bypass, a Roux-en-Y. No, it is, you can just give them your daily nutrients, which is just good enough. They're as it is taking B1, B6, B12, vitamin C, and they're taking vitamin E, calcium. They're taking as routine health.
But after the surgery, they might have some deficiencies.
No, none of them.
None?
None. Because you're not doing anything with the terminal part of the ileum. All you're doing is you're just reducing the gastric volume. You're not reducing their acid. You're not reducing their intrinsic factor. That's a very big thing. By a sleeve gastrectomy, the intrinsic factor is getting lost. And that's where pernicious anemia, gastric cancers come in. So in this, you're not getting that. It is just plain simple reducing the lumen or occupying the lumen. That's all you're doing. You're not doing anything else.
That was an important question, because ultimately you think, are we just doing it for weight loss, or we being it's towards a healthy weight loss? So my next question is a little serious. Colon cancer, it is increasing rapidly. It is one of the third most largest spread cancer, and among 50 years, 45 years, that age bracket, it is gaining. How do you address it? Like what can be done? When should be the screening done? What are the bad factors? What are the red signs?
Yeah, that's a good thing we've brought up on discussion, because it's a very grim picture. Let me tell you that. My last patient was 24 years old with
Oh my
liver
God.
metastasis. I know he's not going to survive more than 3 months. I've had patients who are 32, 36, 40, as young as 18. An 18-year-old boy
180.
came from a village. He had weight loss, bleeding. This was when I was in Tata Memorial. An 18-year-old boy, just fresh out of school, going into college, was excited to go to college with liver metastasis, and I knew he was not going to survive more than 3 months. I knew for certain he would not make it back home also. So when do you start screening? At 50. It's my simple, humble plea on this platform and to all of y'all. It is not a procedure where we want to make money. No. It is a procedure to help you guys. Because if we detect polyps, we can remove those polyps, because these polyps can become cancerous and cause problems. Polyps they form and they become symptomatic at the last stage. That is when they transform into cancer. And then you have to deal with the cancer. So you start at 50. If there's a family history of malignancy, you start at 40. The screening starts at 40. So please, it's a simple test done under sedation. Expert people, there is no problem, there is no pain, there is nothing. You don't have to worry about it one bit. So I urge you, your friends, everybody in the society, like how you all have hepatitis B screening and vaccination, colon cancer screening is the need of the hour. We have artificial intelligence in our scopes at the Breach Candy Hospital, which can tell us where are the polyps, did I miss any polyp? It immediately detects polyps for us. So that's where the advancement has gone up. We are getting software which will tell us which polyps are cancerous, which polyps are non-cancerous. So I don't need to remove all the polyps. And based on the size and the type of the polyp, we do a screening every 2 years or every 3 years. And that's the protocol. But if you all have not had, don't shirk this away saying, Kuch nahi, main to theek hu yaar. Denial. Nobody wants to say that, oh, I don't want to get done. But I think every health checkup hospital should have a screening colonoscopy program. That's one thing which we should do. I think you should tell it in your channels and everywhere. Screening colonoscopy is a must.
US has made it mandatory for
Yes, absolutely.
Since 50 years, they've been doing that. There was a very famous anchor who did a colonoscopy live on table. She did it, and after that, it just shot up. I just wish some celebrity does it on live, on table, and then people will actually understand the importance of a screening colonoscopy. It is a very important thing. You find polyps, you remove the polyps, you're actually curing yourself. Because the polyps can have low grade cancer, high grade cancer, cancer in the polyp. So these are various histological definitions of the polyps. So one has to be aware of it. Similarly, you can do an upper GI endoscopy to rule out Barrett's esophagus. Barrett's esophagus is abnormal mucosa which can turn into adenocarcinoma. It can turn into cancer basically, okay, because of persistent reflux. We are seeing a lot of people having reflux, constant acid, acid, acid. Therefore, that mucosa changes from normal to abnormal cell. Any abnormal cell in your body is called cancer. So, Barrett's esophagus screening, colon cancer screening, these concepts have to come in. When you think of colon cancer, when you have unexplained weight loss, pain abdomen, bleeding per rectum, or on palpation you feel a mass, that's when you think that, oh, something bad is happening in the colon. Mere ko kuch karna hai. And when they come bleeding, means 90% of them are established lesions in the colon. Lesions means cancerous lesions in the colon. They can be polyps, they can be small polyps, large polyps. Now, large polyps can also be dealt endoscopically, what we call ESD, that's what it is done. Endoscopic surgical dissection. You can do EMR, endoscopic mucosal resection. So all these procedures are now done for established cancers. But these should be early staged cancers, not late stage cancers. So ESD is for early cancers. And how do you get them? Once you have detected them. How do you detect them? You do screening colonoscopies.
I think the good part in cancers is if detected early, 80-90% cure.
Absolutely.
And
Yes.
for that, I think it's a regular screening. Like you do your blood test every year, 2 years, 3 years. I think after 40, 45, 50,
Yes.
these should form a part of your routine.
It should be like a docket. Means, and the best way I tell my patients, what's your birth date? Acha, 25th. 25th of every October, do your health check. You'll never forget.
Party karke next day.
So it is.
Truly, I just support him that any sign and symptom should not be taken lightly. It
Absolutely.
should be taken very seriously. In children also, sometimes we get the bleeding per rectum. And the parents, they say, yes, we'll get it investigated, it will come down automatically. But we have to always get them screened adolescent. Say you said 18 years.
18 years, yes.
boy or 16 years
You would never
old
imagine.
girl.
Unbelievable.
Always any symptom, pain abdomen also, recurrent pain abdomen, recurrent diarrhea, and then having the weight loss, as you said. So these are all, one, we have to think of the tuberculosis of intestine, then the celiac disease also, that is, and then of course this malignancy also should be kept in mind.
Absolutely.
Because the polyps, they should be immediately referred and they should be removed at once.
Yeah, they have to be.
I share one case with you. I have a client, so she just turned 50, she was doing my diet and everything. Her weight was hardly 53 kgs. Height was 5'4" and a half. tweak the diet because she thought that she needed to reduce water. She had a routine annual checkup. In US, it is mandatory.
Yeah.
And the moment you turn 50, colonoscopy becomes important. So they don't miss out. And she was diagnosed with stage 3 colon cancer. No symptoms whatsoever, no changes in bowel movement, no weight loss. She was already this weight.
So it's a silent devil in your body.
Of
You
course.
have to address the devil. Like how you said, we have to address the elephant in the room. You have to address the devil in your body. That's very important. Hence, get your screening, get your stool local blood, fecal calprotectin, get your complete blood checkup done, get your CRP done. It's a marker of inflammation, and you can get a basic sonography. So you've got your blood test, you've got your stool test, you've got your sonography. You're pretty much sorted out there. Do you know what was the survival rate in 1947 in India?
47.
In 1947, every Indian, an average age of an Indian, 52, 50,
I think 30. It was less.
55, 56, 57, good. 45, oh, okay.
I think 30.
30. She is absolutely right.
It was
The
30.
average age of an Indian to survive in 1947 was 32. Medical science has progressed. Today, the average age of an Indian to survive has gone up to 70. 70.
70.
Yeah, 65, 70, I would say. Give a range.
So many years
So-
earlier now.
So, therefore,
Invest.
why has this come? It's just because of the marvel of modern medicine.
Absolutely.
And got nothing to do with anything else. So, screening, that's where the point comes. Screening, awareness, campaigns, these are very important. At every platform, in every, you're an insurance agent. You should be telling your colleagues on your, if you're giving a talk on your insurance platform, you need to tell this to people. You're a chartered accountant. Your other, colleagues have to know about this. On every platform, like you should insist as, it's very easy to earn money. It's very difficult to manage the money. That's where chartered accountants come in. So when y'all are wealth doctors. We are health doctors, but the wealth doctors have to tell something about health also when they meet. It's, I think, very important. So getting to your point, they are asymptomatic, okay, most of these malignancies. And as Kshitish said that, 70 to 80% detected early, local.
Yeah.
We have good chemotherapy, immunotherapy, staging is good, and they can be cured. The problem why we are seeing it early, when I started practice, our textbook was elderly, above 65, 70, malignancy. That was one of our differential diagnoses. But now it has come all the way down to 35. Why? Because of all the social life, food habits, all what the ills of the world are, that's what is causing the problem. So you have to be careful. Hence, bottom line again of the pyramid, diet, exercise, self-awareness.
So, doctor, taking you away from the serious discussion, a simple question: how much role does heredity plays in obesity?
It does play a role. It does play. There's genetic predisposition.
How much percentage? Like many people come and they say, "Okay, I am blessed with this heredity, and
Because-
it is very difficult for me to lose the weight." So I just want to know the exact stats.
Stats I might not be able to give you.
There's
I really won't know the stats to be very honest, but we know that there is a genetic predisposition to that, and so therefore you cannot have
Can you
one
see honey?
this into them. Most
Can
of
you
them
see honey?
actually undergo bariatric surgery because genetic predisposition
Oh,
is not going to
I
help
just
with any
pull up
endobariatric or GLP-1 because it's going to be only it's going to be only temporary.
No, nowadays there is something known as epigenetics.
कोई नहीं दिख
also.
रहा है देखो।
So you have certain genes which mark your obesity. आप उनको on या off कर सकते हो. That is epigenetics. Through certain foods.
Researches are still going on.
No, sir.
No,
See,
no, no,
there is
it
a
is-
genetic
there is-
every
there is-
disease that you have now, because we are doing this tie-up with a US company.
Genetic mapping.
No, with Nucleus, where they are trying to map all these diseases at the embryo level. Before we do IVF,
Yes.
we do the embryo screening and then they classify almost 200 diseases even diabetes, hypertension, schizophrenia, colon cancer, all those things at the embryo level. So there's a genetic predisposition, and then epigenetically something that we can modify. I mean, if I might have a genetic predisposition to have a cardiac disorder because my parents and grandparents had, but if I modify my lifestyle to be very active, muscular, not eating junk food and all, I am trying to modify that predisposition to not get into this. But even though there is a genetic predisposition, you can modify it. I mean, don't fall trap to this thing that I have a family or a hereditary disorder, unless it's a genetic disorder which will get passed on. But all these polygenic disorders like hypertension, diabetes, other things, and all metabolic disorders can be actually reversed.
Yeah, we can delay the onset also with the
Reverse, I am saying, not delay on.
Reverse.
Reverse, completely reverse.
Tweaking. So there is a tumor suppressor gene. So sometimes this tumor suppressor gene is very important. It suppresses all the cancerous activity. And we don't know what is the switch which flips it, and the tumor suppressor gene gets activated, and this can happen. The research is going on. We still don't know what exact is the causative agent which flips this switch.
This side
It
of
is
the
still
cell.
there.
Yeah.
So the tumor suppressor gene, the theory is still going on. There's another concept called micro satellite instability. So these are again cells where they're stable, they become unstable. So these are two things in cancer which one commonly hears. A microsatellite instability and tumor suppressor gene. A lot of work is still going on. We still don't know what is the thing, but yes, we've identified that, okay, these are the things and these can cause the problem.
I will,
He
sorry.
said, I fully agree with Dr. Kshitij that this is obesity, the genetic factor, they are multifactorial, it is multifactorial. And once a person is prone for the obesity, now epigenetic factors are nowadays coming up. The maternal, how the insult to the fetus also matters there. Na? So even the environmental sanitation, environmental conditions, now they are predisposing the child. The mother, when the mother is, the child is receiving the nutrition from the mother, from the placenta. So placenta infarcts are formed sometimes. So they modify each and everything. So even nowadays, the overcrowding, the pregnant mother living in overcrowded areas also, the newborns who are born, they are premature also. So everything nowadays, epigenetic factors are becoming very important. So maternal exposure to the various teratogens, exposure to various infections when the child is in the uterus, and also the maternal nutrition also, and all the micronutrient supplementation and all, folic acid and all, everything is very vital, very important.
Yeah.
Epigenetic.
And
So
sleep
all they
hygiene
modify.
also. And sleep hygiene also. Nowadays, sleep to
Yes.
pattern.
So ultimately, it is simply your body whispers, and you have to listen to it when it is whispering. Otherwise, it starts screaming. So you have to make regular scans. You need not shy out कि मेरे को नहीं हो सकता. ये किसी को भी हो सकता है, and you just need to be quite aware of it. Right? Rightly said?
Yes, absolutely. I like that word, whisper and scream. I'm going to take that back home, definitely. Yeah. So, whisper to your body, don't scream at your body. Just have a healthy lifestyle. You can have your cheat days, don't worry. Saturday, Sunday, or Friday night, Saturday can be your cheat days. Sunday again, detox yourself. And play a sport, inculcate some habit, some hobby, very important. And I think, this is what it is. That's all. Thank you.
Wow. I think it was very, very nice. Thank you. Thank you so much.